told you to go to the bathroom before getting in the car. Most oftentimes, intraperitoneal bladder injuries are full bladders, right? So they're full bladders up against a seatbelt or up against some sort of mechanism where they get injured, right? They have a pelvic injury or something, and it causes a blowout. So that's why these are intraperitoneal. That's why it's usually at the fundus, because it's usually a blowout going inwards. And that's a lot easier when your bladder is full. So if you take nothing else away from this, just make sure you pee before every time you get into a car. So now going into some of the renal stuff. So it's not that we're going to go through what the surgical management is, because you guys don't really care about that, but it's important to know when these patients should be operated on so that you know when to push surgery. Like, hey, this guy's got this kind of an injury, or this is what's happening. Like, aren't you guys going to the OR? Or when to have that discussion so that you're not surprised when your patient is suddenly being whisked to the operating room. Again, it's not that you guys are going to be doing this or making this call necessarily, but so that you understand when that call is being made, when that call should be made, that sort of stuff. Right, so absolute indications, patient with external trauma and persistent renal bleeding, right? So if there's an expanding bleeding inside, expanding hematoma, an unstable patient, signs of continued bleeding, are reasons to absolutely go to the operating room. Someone has a retroperitoneal hematoma, right? And that's not something that you might necessarily see at the bedside, but you would see signs of that, right? So we sort of alluded to the idea of patients who may have acidosis, patient who is unstable in any way, shape, or form. Those are reasons why a patient should be taken to the operating room. And then this is something that comes up on CT scan, which of course almost all of our trauma patients get, is if they have an avulsion of the main renal artery, right? Because that implies that there's an immense amount of force there, and that needs to either be repaired or taken out to some degree. So it's grade 5, like plus almost to some degree, right? Or you could have a grade 1, but again, if there's an avulsion of that main hilum of the kidney, then you're not going to be able to watch that, right? You can't just sort of hang out with these patients. And the other caveat to this is, where is the case where a patient would come in with an isolated kidney injury, right? So we talk about in all these algorithms about when to image, when not to image, all that sort of stuff. But in reality, when was the last time you had an MVA that you thought had intra-abdominal injury that you didn't CAT scan? Right? Rarely does that ever happen anymore. So you're going to get a lot more information than you probably need, which allows you to grade these injuries to some degree, and then you can watch them, monitor them, all that sort of stuff. I remember once when I was an intern on the trauma service, and we had a transfer for a patient that they had done an ultrasound for that they thought had a renal injury and had microscopic hematuria. And I remember as the floor intern on the trauma service being like, what do you mean you didn't get a CAT scan? Like, what grade is this? Like, I don't know what I'm doing here. And everyone was like, no, it's just microscopic hematuria, and yeah, there's some kidney injury, but the patient is stable. They've already survived the transfer, so they've already done really well, right? But it was mind-blowing to me that someone thought that there was a renal injury that they didn't CAT scan. But I guess if you have a really stable patient, maybe you don't always have to CAT scan these. I feel like I'm going in circles, because at the end of the day, if you have someone who has enough trauma, you're going to be CAT scanning them, so you're going to have that information. So these are the absolute indications. What are the relative indications, right? And this is when the discussion actually becomes relevant, right? For the absolute ones, like, there's no question, right? You know that those patients are going to the operating room. It's the relative indications where you have a discussion with your surgical colleagues to say, so hey, what are we doing about this patient? How do we manage this patient? Can we watch them? Can we not watch them? So some relative indications are substantial devitalization of the renal parenchyma. That's a reasonable reason to maybe take them to the operating room, maybe watch them, see how they do. If they have anything in the area that is also injured, right? So if the pancreas is injured, if the spleen is injured, if the bowel is injured, those have a higher rate of uromas because there's an associated ureteral injury with all that stuff. If all that neighborhood is injured, you're going to have other stuff to go along with it. There's also, interestingly enough, a high incidence of abscesses with these patients. So they should really be going to the operating room. And in patients who did go to the operating room, it changed their mortality significantly. If you had a concomitant injury with a renal injury, your mortality went from 85% to 23%. That's a pretty impressive mortality change just for going to the operating room and, cleaning things up, fixing things up, whatever the surgeon people do, right? However they do it, whatever it is that they're going to be doing in there. The fact that they went to the operating room and did something actually was very life-changing to some degree, right? So those are the patients who you'd say, maybe there's a little bit of a bowel contusion and maybe there's a renal injury of some mild sorts, and someone says, well, let's just admit him to the floor, or admit him to the ICU and let's just watch him for a little while. Seems reasonable if all of those things are very mild injuries, except when you have concomitant injury, that changes the mortality of that patient, right? So those would be reasons to go.
When it addresses surgical repair there, is it addressing any surgical repair, like whether they fix the concomitant versus the renal?
So in this, it was mostly about fixing the renal injury, right? You deal with the other injuries as well, but this was more specific to the renal injury. Yeah. So it's, do you do a partial nephrectomy, right? The part that's injured. Do you repair whatever is broken? Whatever that management is of the kidney injury. This is in relation to the kidney injury. Great question. This is also where it's really important to know your mechanism, right? How did the patient get injured, right? As Bob was talking about, patients who got hit on the driver's side of their car and had an intrusion had a higher incidence of kidney injury, right? Versus if you get hit somewhere else, and that might not necessarily be the case. The mechanism does actually matter. Were you thrown from the car? Were you wearing a seatbelt? Did you get shot? Did you get stabbed, right? In terms of penetrating injury, that will also change things. Isolated penetrating injury with a stab wound is very different from a gunshot wound, right? It's all penetrating, but the mechanism does actually matter, and that will change what you do and how much you do for the patient. Right. Any questions so far? So when would you not do a CT scan if I didn't already say this? Right? Perhaps if you had someone who had an isolated stab wound, had an isolated injury, and you didn't see much, you did a fast exam and that was negative, and you got a UA and it showed microscopic hematuria, that might be someone I might be willing to say, maybe we'll just watch it and see how they do, right? But in almost all of these cases, you still need to grade them, and to grade them, you still got to do the CAT scan. And we are unfortunately bound to our CAT scanner in many different ways, right? So there are very few instances in which I would feel comfortable not CAT scanning a patient who I thought might have renal injury. What do you guys think in the back?
In the other direction too, if they're too unstable to go to CAT scan, they have to go right to the OR.
Right, no, yeah, absolutely. Yeah.
What about I feel like the classic test question is maybe the person who is in an altercation who's otherwise well appearing, they're not entirely a multi-trauma, or they have normal vital signs, and the indication isn't even necessarily to look for the microscopic in that setting.
Yeah, I think that's a great scenario, in which case you might argue if someone keeps complaining of flank pain after they got punched, to perhaps just do a UA in that case, right, to see if there's something that you need to deal with or not. Would you feel comfortable if the patient who says, I've got severe flank pain, and you do a UA and it's negative, would you send them home? Right. Yeah, I mean, I would argue it depends sort of on the patient, right? If there's still complaining of a lot of pain and I would probably fast them in that situation too, at least. You have it makes us feel better to have imaging of some sorts. And maybe obs them for a little while or watch them. We don't obs our trauma patients yet, but.
Also the pregnant patient.
Yeah, pregnant patients are a whole different entity, just because their anatomy is a little bit different, all that sort of stuff. So we didn't really touch upon that, just because with pregnant patients, everything becomes different. Your imaging is also always in question to some degree as well. But of course, mom comes first in any of those scenarios, right? If you have someone who has significant enough trauma, mom comes first, and you sort of deal with that. And you can make arguments that like MRIs, while safer for baby, is not the right place for mom to be at that time. So if you have to image, you have to image. If you can get away with just ultrasounding someone and getting some more information there, then yeah, that would be the best case scenario. But those are slightly more dicey situations. So in celebration of your oncoming in-service exam, I thought we'd do some questions. So here's a patient, 19-year-old Brooklyn medium male, who's brought in by EMS for a gunshot wound to the abdomen. Initially, his heart rate is not so bad, 90. It's expected for a guy who just got shot. Blood pressure is 109/68, and he's got respiratory rate 20, O2 sat. That looks pretty good. You do your primary survey, as you are all astute traumatologists, and you note a gunshot wound to the left flank, right? Remember, these are just wounds. There are no entrances and there's no exits, right? You're not scientific forensic scientists. You're ER doctors, so these are all just wounds. These are never entrances and exits. And you do a fast exam, and I don't know if you can see this image. I don't know if they'll play for you.
Stand down towards the wall.
I don't know if you guys can see the image well enough in the still image.
Yeah.
That works. Can you guys see it? Who sees it? What do you see?
It will call reading is posterior to the kidney.
I see a hypoechoic area. Yeah, we can just leave it there. Yeah, that's fine.
Free fluid.
Free fluid somewhere around the kidney, right? You guys see it up here? There's a black stripe right here. Everyone sees that black stripe? Right? So decent sized stripe going all the way around the kidney. So what are you going to do? What did you already do for this patient? No, you called the trauma code. Right? You guys had a penetrating wound to the abdomen. You already called the trauma code, right? Step one. So while doing your exam, you notice the blood pressure is 90/50 and the heart rate goes up to 102. He's yelling in pain because again he just got shot and he's yelling that I got shot. So you redo your fast exam because it's always a great thing to do when there's a sudden change in someone's vital signs. And then as you finish your fast exam, someone redoes the blood pressure and all of his vitals, and they look great again. So now what do you do? What's the conversation you expect to have with your trauma colleagues? Who wants to do A? I mean, we all want to do chest tubes, but maybe not this patient. Who wants to do a CT scan? Okay. Who wants to encourage surgery to take him to the operating room? And someone wants to give some fluids and see how the patient does? Right, so there's a division between B and C. It's a very appropriate. Thankfully, no one picked A or D. So the difference here is this is a seemingly stable patient with a penetrating wound to the belly, and you don't know where it's going. So it seems reasonable to want to do a CAT scan, except that you've got unstable vital signs, and you can argue that while that first set of blood pressure is not necessarily crazy, but there is some change or some fluctuation. So now before this guy really opens up and starts bleeding, he should be in the operating room being explored. Right? So the correct answer here is to encourage surgery to go to the operating room. All right, 18-year-old woman who's a restrained driver presents to the ED after a moderate speed head-on collision. She's complaining of lower back pain. She's got some vital signs. They don't look so bad. The physical exam reveals an alert female, soft abdomen, slightly paraspinal lumbar pain when you palpate on her. Fast exam is done, and it's negative. It's done a little bit delayed, but it is done. And she's got a pregnancy test that is negative, thankfully. And she has a UA that shows some RBCs. Right? What do you guys want to do? Anyone want to do A? Anyone want to do B? Anyone want to do C? Anyone want to do D? You guys are all really torn on this one, huh? Yeah, this is why we're here. So the answer is actually to discharge, right? So the key was, and perhaps I glanced over it slightly, but the idea that there was a delayed fast exam, so she survived the tincture of time to some degree. She had a UA which only showed 25 RBCs with a relatively isolated mechanism to some degree, right? So this is someone who, according to the AAST guidelines, would be okay to be discharged and followed up, right? So while we may not always practice that, that it is actually appropriate management. And that is an official test answer. That's not even me making up questions. So the reason why CT would be appropriate, except if there was gross hematuria, it would be more appropriate if there was any signs of shock or suspicion for any other intra-abdominal injury. Obviously, gives the answer. Foley catheters you could place, but then if you get 25 RBCs, is it 25 RBCs because of a traumatic placement or because there was a true injury? So that sort of becomes a little bit different too. And then also retrograde urethrogram is indicated if you think that there is a urethral injury, which we don't suspect in this particular case, right? There was no other signs that we would think about that kind of stuff.
But in reality, you would sit on that patient for a while, observe, and then re-examine after 4 hours. That's why.
Yeah, so in this scenario, they were already watched for 4 hours. And you could sit on them even longer if you really wanted to. Yeah, sure. Next one, we'll do one more. 42-year-old farmer presents by ambulance. I know we get so many of those in this neighborhood. After being pinned against a wall by a tractor. He's non-ambulatory on scene. Arrives to the ED. Here are his vital signs. Anyone concerned about his vital signs? He's pale, diaphoretic, complaining of severe pain in his hips and groin. A fast exam shows no intraperitoneal or intrathoracic free fluid with no evidence of pericardial effusion. And you get this pelvic radiograph. That's the appropriate response. That's the appropriate response. So what do you guys want to do? Who wants to do A? B? You want to feel it? Feel it? Rock and compress the pelvis. Anyone? That was a fantastic response. Thank you. I appreciate that. And B? Yeah, right. This is the guy. You take the sheets and you wrap them up. And you remember how to do it because we did that earlier this year. And if you forgot, I'm always happy to teach you how to wrap in a pelvis appropriately. How do you check for pelvis stability? What is the test? How do you do that test to check?
Medially.
Who? Someone say it. Everyone's mumbling.
Press laterally.
Yeah. So you grab the posterior and the anterior ACIS and you compress, right? And you look to see if that moves or if the patient says, "Ow, that hurts" when you do that, right? None of this grabbing on and then shaking and rocking. And a lot of people still do that. Because yes, that will elicit instability, you're absolutely correct. But what that will also do is disrupt the posterior pelvic plexus, right? And that's a venous plexus that sits along the backside of the pelvic bones. So when you start rocking and opening up all those joints, if they do in fact have an open book fracture or really any pelvic injury, you're going to open up that pelvis and then they're going to start bleeding, and that's when they decompensate, right? So the one that matters is the open book. That's one you can intervene on. They all matter. This is the one that we can intervene with. So all you're doing is squeezing inwards, and only one person does it. There's no wrong answer by putting a pelvic binder on someone who didn't really need it, right? There's no harm necessarily unless they have like a lateral compression or some other types of pelvic fractures. But in this case, yes, a pelvic binder would be the correct answer, right? So you wrap the sheets, and you go across the greater trochanters, right? We always feel the pelvis sort of at the ACIS, but in fact you're binding down at the greater trochanters, and that's what holds that pelvis ring sort of in place, basically. Okay. Yeah. Any questions? Yeah, we got.
So for the first question we had, the patient had first a hypotensive reading, and then the next one was normotensive. What's the time course, or like, is it acute, the activation of the renal angiotensin aldosterone system? Is that something we'd see in the ER, or is that like later in the ER?
Well, it's unknown, right? So at the end of the day, if I have a patient who's got a labile blood pressure and heart rate, that's someone who I'm going to assume is all secondary to their trauma, right? And especially in young patients, they have a really impressive catecholamine drive, right? So if you notice a lot of our patients who come in with normal blood pressures, you give them a little bit of pain medication and they suddenly tank. It's not that something magically happened, it's that they had a good catecholamine response driving their blood pressure and heart rate up. And then you gave them some pain medication and you relieved that catecholamine drive, and now you're uncovering their underlying issues, right? Their underlying instability. And then if it goes back up again, is it because some system kicked in, or is it because the medication wore off and now they're in pain again, right? Or something else might be going on. Right, things to consider. Either way, in the acute setting, I'm going to blame the trauma. Yeah.
I was wondering why 50 for microscopic image area? If it's greater than 50 red blood cells per high power field, it suggests you're getting imaging. So why?
I think that was
so
just-
microscopic image area.
Go for it.
No, I think that's just their definition of micro versus gross. Greater than 50 in a high power field is considered gross.
It's a lab thing,
Yeah.
right? And once you get past the 50 mark, then you should be able to see it. Any other questions? All right, thanks guys. Great job, guys.